Okay, guys, welcome back. I hope you heard me. I'm so sorry. I hope you heard me. Do you hear me? If anybody can write in the chat box that they, yes. Okay, I'm so sorry for the technical problem occurs and this connection appears. I could not contact with you for several minutes. I'm so sorry for that. I missed the time because I could find many. Oh yes, I received many yes. You know, I had in the previous 2 years, I had a workshop, evidence-based dentistry. It was amazing. I could find many friends. So when you are here with me, I feel that I could find many friends, and I do not like to miss you any times. I wish and I hope. I could not say wish. When I say wish, it means that it might not come true. But I say I hope we can keep this friendship together now and for always. And during this period of time, 5 days, you could somehow, somewhat get familiar with Persian land, with Iranian culture, real Iranian culture. We are Iranian. We like kindness, friendship, and we invite you here one day. Please come to Tehran and Iran and see the reality, not those, and see the reality, not those that is advertised in media. Please do not trust on the media. Trust on the reality. Come here, see us, and we meet you. Okay, we had several questions. Oh yes, thank you, Fatima. It would be our pleasure as well, dear Fatima. I hope to meet you soon, in near future, after COVID-19 disappear. I hope the COVID-19 disappear very soon. Okay, we have several questions. I hope I could answer the questions. Dear guys, if you have any other questions that I answer your questions. If you do not have any questions, I have several cases. I would like to present these cases to you, and any of the friends and guys can answer the questions. Please raise the hand, and then we unmute that guy, and I will ask that the friends that turn on the video and commence the treatment plan for that tooth that has received endodontically treated. Okay, I know I show the several cases. One second. نه نمیخوایم بریم. Okay. Now several cases will be presented now. I will my friends to show it now one by one. Okay, we have 3 cases. Okay, I show the first case. The first slide. Okay, guys. According to those papers that was uploaded in the NAVIS system, and probably have read them, or you are familiar with treatment planning of different condition of the tooth that has received endodontically treatment teeth, I would like to ask my friends, the guys, about the recommended treatment planning of these 2 tooths. One of them is the second premolar, laber molar, and the other tooth that has received endodontic treatment is the first molar with 4 remaining wall, and the other one, the premolar, with the 3 remaining wall. Please raise your hand if anybody can answer. Definitely all of you can answer, but please join us in order to have a good contraction together. میشه لطف کنیم بیاین من یکی رو میخوام انتخاب بکنم. Okay. Nobody raised hand probably. I would choose among the guys that has participated in the program. I would ask one of the friends, Seda Sifty. I don't know if I pronounce it properly. Seda Sifty. Would you please unmute your microphone and turn on your video? Seda? Seda, I'm waiting for a reply. Please do not be cool in the morning. The sun rise recently. We should be active. Please, my question is that what is your treatment planning for the lower second premolar, as you see in this slide, that has received endodontic treatment? We have 3 remaining balls. Okay, apparently Seda still cannot answer my question. Probably she's sleepy because it is the morning. So I would like to ask another guys to answer the questions. Let me see the participant and choose among guys. Or anybody wants to answer the question. Oh, one of the friends joined us. Hello again.
Hello again. Hello, Dictor.
Hello. Thank you that joining us and accepted to participate and joining us to answering the question about the treatment planning.
No, actually, thanks to your asking, thanks for your question. The answer will be only the opinion, but the question is difficult to take.
Okay, any answer do you want? If any answer comes to your mind, please tell it. We can talk about this issue. Don't worry about probably any mistake. We are here to have a mistake, then we improve each other. Okay?
Thanks.
So,
okay.
Noor, please let us know if the second premolar, not if, you can see the second premolar, lower premolar has received endodontic treatment. Here we have 3 remaining valves: buccal, lingual, and mesial, and just the distal portion has been lost. If this patient is referred to you, what is your treatment planning for restoring these tooth? Please let us know. Anything you want to say, let us know. Don't worry about any probably mistake. Don't worry, let us know.
Thank you. Firstly, we'll see the root canal. If there is any inflammation or something in the root canal, or if the root canal will be safety and full out, then only the crown need to prepare. If the root canal is safety, there is no inflammation in the root canal and full correctly, we are going to see the crown. We will use the matrix, then we will build the layers step by step. And at the beginning, we will do the dentin layers. Then if there is any needed, we will do second steps to be more stronger. And then we will put the composite for the enamel and use them. We will use the matrix, of course, to make the edge of it at the beginning. Then we will build step by step till the end, and we will do the shape, then polishing, and it will be amazing.
Great, it's wonderful. So for these tools, your treatment planning will be direct restoration with the composite resin. Is it right?
Yes, but I will ask you a question now.
Okay, let us know.
What do you think? What's your opinion if we will put the supportive panel here?
Panel?
Because this is, yes, if we will put small supportive panel here. What do you think about it?
I could not understand. More supported panel?
Supportive things. If we will put some panel or supportive things in this area to support, and we will build on it.
No, there is no need. Do you think there is any need? Because we have here in this premolar, we have 3 walls, very thick. There is no need to use any material to support the remaining tooth structure. Already the tooth structure have enough resistance. The thickness of the wall is high. No, please. The thickness of the remaining wall is good. We have lost just distal marginal ridge. So as you explained, these tools can be restored directly with resin composite, as you explained in more details, layer by layer. It is the best options. Thank you for your answer.
Thanks for your question.
Thank you. Please do not leave us. Keep contact with us. I ask other guys in order to communicate with each other, because the aim of this winter school is in the interaction to reach a common idea. Please do not leave us. I will ask another friends such as Sealant, Thailand. I do not know. I can spell your name properly or not. Seda has answered that I was here, but I had a problem about MCI and camera. I tried to join from phone and I forgot to allow the camera and mic from setting. So by this way, say that you cannot join us as you explain. I'm so sorry for any technical problem we have. Okay, Selan, I'm available to open my camera and MIC, but I can't write from the chat box. You can write it. Yes, you can. If you cannot contact with us with camera, please write in the chat box. What is your treatment planning for restoring the molar? Another slide, the first molar that has received endodontic treatment. What is your suggestions? Noor is available here. Please, guys, if anybody has any comments, please raise the hand or write in the chat box in order to communicate each other, because I want to reach a common points at the end of these sessions. Okay, maybe a composite restoration. Great. Thank you, Selan. Would you please in brief why you choose the direct composite restoration? Very briefly, what was the reason, Selan? Tree or fall wall still elastic. Exactly. Noor, do you agree with the answer of Selan? Do you hear me? Noor, unmute yourself. Unmute your microphone. Do you hear me, Noor? Please provide accessibility for Noor in order to unmute the microphone. For Noor Mistan. My colleagues try to unmute you, okay? Don't worry about it.
Thank you so much.
Okay, can hear you. Okay. Noor, do you agree with their treatment planning that Selan recommended for restoring the first molar that has received endodontic treatment?
What she answered?
She answered that these tools can be restored with composite restorations directly, I think so, because there are 4 walls. Do you agree with her comment?
I think, as you said, as you explained to us, I think is it true, because we will use the matrix and we will build step by step using the dentin and the enamel, and we don't need to do like extra things. But the first things that we should need to know the root treatment, the root canal treatment, because you know why I said 2 times like this. Before 2 days, not before 2, before 2 weeks. Before 2 weeks, one patient come to the clinic and he has very painful in his tooth, in his first premolar. He came and he said, I was very painful, I can't sleep. He took X-ray and we saw in his tooth, the doctor previously, and the previous doctor, he did a restoration and root canal treatment. The doctor didn't fill all the root canal treatment, he filled near the apex. And this patient has inflammation in the apex of the roots, and he extract his tooth. Okay. So the mistake of doctor was
I got your point. Before restoring a tooth, we should be assured about the quality of the endodontic treatment. That's right. You're absolutely true and correct. So these cases that is presented here, we assume that the endodontic treatment is the quality of endodontic treatment is fine. But your consideration is absolutely great and appreciated. Before restoring the tooth structure, the coronal tooth structure, we should be assured that whether the quality of endodontic treatment is right or not. If it is not right, we should retreat it. That's right. But these cases that have been presented are those cases that we assume that the quality of endodontic treatment is fine. Okay? Okay, I would like to ask a question from who? Ahmad Amir. Do you hear me, Ahmad Amir? Or Amir?
Yes, I do hear you.
Oh, hello. Good morning. Is it good morning for you? Oh,
Yes,
hello.
yes, it is good morning.
Oh,
Good
I'm
morning
so
to you
happy
too.
to meet you. Thank you to joining us and turn on your video. I can sense, I can feel you. Thank you for joining us.
You are welcome. You are welcome. Thanks to you.
Your hat is beautiful.
Yes, thank you. Thank you so much. I think so too.
You're so handsome. Most welcome to our and thank you for joining us. Okay, Ahmed, please give your idea about both these two cases, about premolar and molar. Would you please give your comments about the type of restorations for premolar and molar that you can see here?
Well, I couldn't agree more with the guys who just mentioned that the composite, I think it would be a proper treatment, since I believe that the premolar, it is already like treated endodontically. So I think like the composite would be a good treatment approach. And the same with the molars, since there are like 4 walls, which it makes like the retention somehow normal. Like functional. We know that the forces, the mechanical forces on the molars, that it is excessive and a lot. So, but there are like still a hard structure of the tooth, seeing the walls that it is visible. So yeah, I would agree to that. Composite material, it would be also a good approach. Adding to that, it will not cost so much, like it won't be expensive for the patient who is coming. So yeah, I would like go to that.
Okay, and one question I have you, according to the video demonstration that you observed, do you think for this molar, first molar, do you use wallpapering techniques or no? You just fill the cavity with composite resin. And what is the reason for each of the treatment planning you recommend?
That's a good and a tricky question, to be honest. All right, so like for the premolars, I think, yeah, it is fine since we have to build walls. But for the molar, I don't know, like since this thing is like totally new and I don't know like the total function or the indications of this like using these fibers. So I would go to that. Yes, why not? Like it can be, since it has the same composition, I guess. So it would be a good idea. Why not?
So thank you for your comments. And now I want to give my comments. I use fibers in order, the aim of using fibers is to aim, is reinforcing the material by itself. The other aim is reinforcing the tooth structure. Is it right?
Yes, that's true.
So the aim of using fibers is improving the strength of the material by itself or improving the strength of the remaining tooth structure if the structure is weak. When I see these two tooths, premolar and molar as well, the thickness of the remaining wall is amazing. They are thick enough. They have enough strength. So if I want to use the fibers, they would not be helpful to improve the strength of the remaining tooth structure. Because the tooth structure, if you have enough thickness, there is no need for further help.
Okay, I changed my mind. I will not use it with the molar.
No, I just gave my comments because we share our comments together. The aim of this program is to share the comments to reach a common point, okay? Don't worry. If anything you want to say, please let us know. And also Noor and any other guys, if you have any comments, if you can write in chat box or raise your hand, we can unmute you and share your screen, your video. So using fibers, whether in premolar and whether in the molar, there is, I think it might be useful to me. It adds some interface. I try to avoid increasing the interface as much as possible. if it is indicated. So I think I do not need to add interface by using fibers in these two cases. Noor, do you agree with me? You can unmute yourself. Do you agree with my idea, or do you agree
Yes, of
with
course,
using fibers?
completely. No,
Okay.
yes, of course. Your idea is
Okay.
so great.
Thank you. Thank you. And also, Saeb Alizadeh, for premolar, we can use inlay for molar direct restoration. Saeb, thank you for sharing your idea with us. Appreciate that. Inlay. For inlay, yes, we can use it, but think about inlay. Inlay is an indirect restoration. For preparing a tooth for inlay restoration, what you should do, please think about it. You should prepare the tooth in order to diverge the wall, in order to be able to have an impression. If you want to diverge the buccal wall, exactly, more specifically on the buccal wall and lingual wall, do you think we lose more tooth structure? Because our aim is to save as much as tooth structure conservatively. Yes, inlay is one of the treatment options, but whether my aim is achieved or not, is the aim is remaining and keeping and saving the remaining tooth structure, with choosing inlay as an indirect restoration, I will lose more tooth structure. So my aim is not provided. So if I were you, I will not select, or I will not choose inlay for restoration of the premolar. I do not know. Could I answer your question, or if you want your any other question you have about my answer in the chat box, or if you want to unmute yourself in order to be able to explain more? I would like to ask Noor and Ahmed that is available now. Do you have any comments on my answer about inlay in answer to the Saeb? Do you agree with me? Okay. Farida, this case question was super idea to make us understand use of that technique properly. Thank you, Farida, about your comments. So a wallpapering technique, as was shown in the video, is for tooth with the 4 remaining wall, not so thick like the slide that you can see here, not so thin and fragile. Immediately, okay, meet between these two. I hope that everybody understands it. Okay, if you agree, we go to the next slide. Please let us know, let us show the next slide. You can see these two tooths. One of them is the upper maxillary premolar with an MOD cavities and excess cavity for endodontic treatment. According to recommendation, good recommendation of Noor, we assume that the endodontic treatment has good quality. We do not want to retreat it. Also, we have a molar that has received endodontic treatment. Again, we assume that it has a good quality. Abdul, hi doctor, what can you say about amalgam filling? Now I will talk about it. For amalgam filling, for the previous slide, for the first molar, you can use it because we have 4 remaining walls that they were thick. But it's not a static point of view. Also, it has been said, it has not been confirmed, that the composite restoration might reinforce the remaining tooth structure temporarily, not for long period. So the composite restoration might reinforce the remaining tooth structure for a short period, not long period. For example, 1 year, 2 years, not excessive amount of time. So if I were you, I fill the cavity for the first molar. For the previous slide that has just an excess cavity, I used composite instead of amalgam. But you can choose amalgam as well because the remaining tooth wall have enough strength. They are not very weak. Do you agree, Ahmed, with me? Do you agree?
Yes, doctor, I totally agree with you. Yes.
Okay, thank you. Now, because of the time deficiency, we should be faster in order to give the treatment planning. Okay, we have just 4 or 5 minutes. Please let me know about the treatment planning for the first premolar and first molar. What is your opinion? What is your comments for treatment planning of these two tooths? Selan, please help us. Amir has answered. Class 1, use matrix for filling after wallpaper. Amir, for the previous slide, we do not need wallpapering technique at all. We do not need matrix because we have 4 remaining wall, and this wall acts like matrix, so we do not use it. But for the class 2 premolar cavities, in the previous slide, yes, we use the matrix to provide a artificial wall in order to restore the tooth. Alexandra asked, for the premolar, we can use an indirect restoration such as, exactly. Alexandra, thank you for answering the question. And then Seda answer, I think in both cases, indirect restoration can be perfected. And Behna's answer, inlay. Okay, guys, because of the deficiency of time, I have no time to ask your idea. I try to explain to you. If you have any further questions, please communicate with us because we have deficiency of time. We have MOD cavities. We have a tooth that has lost vitality because of the endodontic treatment. So we have lost the core of the tooth tissue as well. So the integrity of the tissue has been lost. The strength of the tooth has been reduced. We have lost 2 marginal ridge, which is fundamental for the strengthening of the tooth. So I have to choose a treatment planning to improve the strength of the remaining tooth structure. What would be a restoration that costs capping the remaining tooth structure and distribute the stress in the remaining tooth structure? If I use inlay, definitely it will cause tooth fracture obliquely, and the tooth cannot be saved. I should something that cause cost coverage. The overlay, endocrine, or only provide the cost coverage of the remaining tooth structure. I do not know. Ahmad or Noor agree with me, or other guys? Farida, agree with Alexandra. Alexandra has been written, for premolar, we can use indirect restoration, definitely. Not inlay, but overlay, as you mentioned. So we reduce the cost about 2 millimeters to provide the thickness for the ceramic material, for Emax, for example, Emax or lithium disilicate or composite lab-made material, but not inlay, because inlay will cause definitely like wedging effect. It causes wedging effect, cause fracture of the tooth. So definitely we will avoid inlay restoration for these teeth. Seda asked, IDS may be required for strengthening the wall. IDS is the abbreviation of immediate dentin sealing. For any type of indirect restoration with adhesive protocol, recently it has been recommended to improve the bond strength after tooth preparations and before taking impression. Immediate dentin sealing is performed by self-etching adhesive agent. Another question, by post-core we can keep tooth. Definitely you should avoid post and core. It's a traditional method of tooth restoration because our approach today and the protocol nowadays is to save the remaining tooth structure. By using post and core and tooth preparations for crown, you will lose any remaining tooth structure. So please, Saeb, avoid traditional treatment planning if the remaining tooth structure have enough thickness, as is not fragile. For these two tooths, as you see here, you should avoid post and core. And for Saeb, fiber posts are the most efficient one. Saeb, why we should use post here? There is no need for post. Who wants to choose overlay cost coverage with any type of material like ceramic or composite lab base. So post, the aim of the post is retaining the core. We do not need post and core here. So try to avoid post, using post, any type of post, might be metal or fibers for these two tools, because the treatment plan is not post and core and crown. And the Muhaddis Panahi have asked that, can you use interdentin pin for premolar? Definitely not. Why I should choose pin, intradentin pin? Because pin cause fracture line and tooth. What is the reason for pin? We can restore the tooth with adhesive protocol, with the cost coverage restoration, with an overlay. So try to avoid any type of post and core and crown, avoid any type of pin for restoring these tooth. Would you please show the last slide? Okay. Welcome, Muhaddisa. This slide is shown to you why we should avoid inlay, as one of the guys has recommended. If you use inlay, as you see in the figure C, when a force is applied, it would cause wedging effect and cause the buccal and lingual wall separated. And finally, they will broken. Can you see in the figure C that the palatal wall or lingual wall has been broken obliquely and might be extended under the crest, and the tooth might not be saved, even the crown lengthening or forced eruption of the tooth? So if you choose inlay for this type of cavities, definitely you will speed up fracture of the remaining wall. But if you choose the treatment plan as shown in figure E, you will save the tooth. You will distribute the forces and improve the strength of the remaining tooth structure. In the slide, in the figures that you in the lower row, you can see different fracture of the tooth that has, this teeth has received endodontic treatment, has lost two marginal ridge, and restore in the first molar directly with composite resin, MOD composite resin. There was no cusp coverage, so the tooth was fractured in the middle because the buccal lingual cusp could not be distribute the force. So like the inlay, a wedging effect, two wall has been separated. You can see on the middle figure, the cavity, MOD cavity, was filled with amalgam restoration with no supporting. If I remember, one of the guys has asked about the cusp coverage with amalgam restoration. If these figures, figure in the middle figure, was cusp coverage with amalgam restoration, again the force was distributed. Fracture did not occur, but unfortunately, the teeth was filled directly MOD like inlay with amalgam, so the tooth fractured. So one of the options, treatment options, would be only overlay with amalgam, but the cusp coverage definitely should be performed. And you can see in the last one, the first molar, that this first molar, upper first molar, MOD cavities, endodontic treatment, treated directly with composite restoration, no cusp coverage, again fracture occurred. So please, my aim in this session for this slide, please reach a common point and then finish our program. For any tooth that receive endodontic treatment, just as have lost two marginal ridge, that has a fundamental rule in strengthening of the tooth, always consider cusp coverage about any type of material you like. It could be amalgam, it could be ceramic, it could be composite restoration. The type of material will affect the static, the type of material will affect the longevity of the tooth, of the durability of the restoration. For example, amalgam might not be strength enough to give you a service, for example, for 30 years. But ceramic, lithium disilicate, Emax might have enough strength to have more durability, especially from the staining, because ceramic does not accept staining like composite restoration. Always you can also you can choose the material composite, but overlay, cost coverage, but the composite in the duration of time might wear and lost the form, and also because of the staining discolored. So we have reached the end. Farida asked, doctor, I want to ask you about post metal versus fiber. Fiber is most fresh version and advice for its flexibility. But I heard that after some time passed, it's going to be damaged and separating inside. What's your opinion? Thank you, Farida, for a question. Yes, we always should choose a material that have a mechanical property similar to tooth structure. Metal posts are stronger, but the tooth has flexibility. And because of that, fiber post has recommended to have the flexion similar to dentin. But be sure, and we know that fiber post does not adhesively bonded to root canal structure. It's just say it is adhesively, but you cannot adhesively cement it to a root canal tooth structure that has been contaminated with the sealer, with the remaining gutta percha, or the dentin has been affected by different irrigant. I recommend fibers, not I recommend, according to the evidence-based dentistry, according to the papers, fiber post might be preferred in somewhere instead of the metal post. But as you read here, as you wrote here, after a while, the adhesive joint between the fibers and the tooth structure will be disrupted because there is no bonding there. There's just whether this is metal, whether it is fiber, majorly the retention is mechanical, frictional, not adhesion, true adhesion. And because of that, you have written or read somewhere, you have saw that the fiber post has been separated. That's true, it hasn't occurred. And so what's your advice for best results? As I told you, we should try to use the remaining tooth structure to restore the teeth with adhesive protocol, even with endocrine, with overlay, anything to avoid entering the root canal. If you enter the root canal, you need to remove most tooth structure to provide the space for the post. So again, you danger the structural integrity of the tooth. So try as much as possible, try to avoid the treatment planning that need post. Post and core and crown will remain just for cases with extensive loss of tooth structure that nothing has remained. If nothing has remained, post is useful to retaining the core in order the crown is placed over it with a Froll effect. Never ever forget having a Froll effect. Otherwise, the tooth has received crown, post, and the core and crown will be fractured. I'm sorry. The time has finished already.
Last question, Dr. Fariba, please. Can you just give me the spelling of the Dr. Berry or Berry something?
Dr. Ahmed, would you please refer to the Navid system? I have uploaded the full text of the articles. I may not pronounce it properly now. I made a mistake. Read the articles and see his name. Then you can find it there. Is it better?
Thank you.
Okay.
Last question also. Last question.
Yes, please. We have no time. We have no time.
If the patient will come to you and he has a bulk of caries, a huge amount of caries, and you will restore his caries, and there is a thin wall in the caries, he will say, I don't want to put Zargon or ceramic because my financial is so less, I don't have money. So do you recommend to put composite or amalgam to it?
If there is thin wall, any remaining thin wall should be reduced. Don't forget it. So we remove the caries, we reduce the thin wall, whether you want to restore it with composite or amalgam. So any remaining, if the wall is high and thin, definitely you should reduce it. Don't forget it.
Okay.
It's not dependent on the type of material. It's a mechanical issue, like a building. like a wall in the building. When the wall is thin and long, definitely it will be fractured. Otherwise, it's overlay, like a roof. Don't forget to make a roof for the tooth or teeth that have thin wall. Make a roof for that tooth. Okay, is it clear for you?
Very clear. Thank you so much.
Thank you. And Farida, doctor, please comment us textbook for resto class. Thanks in advance. Thank you for participating and joined us and active participations. The textbook that is used in the restorative dentistry departments is the Summit book. I will write the full text in the NABIT system if you wants to join it, and several other reference books. I will write it in the NABIT system. You can go to NABIT system. You have access on it until I think on the Friday. Don't worry about it. You will have access to NABIT system until I think tomorrow. I will rewrite today the name of the textbook you can refer to. Okay, guys. Thank you all of you for joining to us. Thank you for active participations in this group, in this conversation. I hope you have achieved a good result in order to treat the teeth of your patient properly and according to evidence base. Please do not forget to read articles, and especially the systematic review and evidence-based dentistry, that what treatment approach is the best for your treatment, because you are very good dentists. And I hope to see you and meet you in near future at TUMS Dental School as a postgraduate student as restorative dentistry department. I hope on it. I'm sure that it will. My wish comes true. Without any coronavirus pandemic infections, in complete health and safety. Please take care and thank you. Be with us. Please do not disconnect with us. We are friends. Please keep your connection with us. Bye-bye, everybody. Good luck.
Hello, everybody. Welcome to the Pediatric Dentistry course, the last clinical one, I guess. I know that this is the last day of your inter-school program. I would like to first welcome you on behalf of myself and our department to virtually have you here in the Tehran University of Medical Sciences. And I hope that in the near future, we will have you here in person in our departments. As delegates of the Department of Pediatric Dentistry, we will have some lectures. First of all, Dr. Saida Mokhtari is going to talk about preventive resin restoration and fissure sealant treatments that might seem a little bit easy, but they are really technique sensitive and they might have some very bad consequences if they are not performed precisely. And afterwards, I will change positions. I will have a lecture about the stainless steel crowns in pediatric dentistry, the procedure, the usage. And at last, we will be hosting Dr. Baghalian, who will talk about restoration of anterior primary teeth. In these days, with high prevalence of nursing caries and early childhood caries, is a very demanding procedures. Now, instead of wasting time, I'm going to ask Dr. Mokhtari to start her speech. Dr. Mokhtari, the platform is yours.
Hello, Dr. Minani. Thank you very much. Hello, everybody. In the name of God, I'm very happy to be here. And I hope what I want to talk about will be useful for all of you. In these days of COVID-19 pandemic, I hope you are in a healthy and good status with your all families. And I think these days you hear much more than before about the prevention. And I want to talk about an important preventive dental care. I mean, fissure sealant and preventive resin restorations. I know all of you know about them, and I'm just going to have a brief review. Okay, as a dentist, all of you know that dental caries is a very common chronic disease that affects more than 90% of adults. Despite all of the dramatic improvements in the prevention of dental caries in the past decades, it is still the single most common chronic disease of childhood, more common than asthma and hay fever. And beside the high prevalence dental caries, have an unequal distribution. It occurs more in children in low-income families and who live in poverty. Moreover, the pattern of the dental caries have been changed. In the early 1970s, smooth surface lesions accounted for almost 25% of DMFT index. Recent data show that about 90% of the dental caries in permanent teeth occur on the occlusal surfaces. Like permanent teeth, also primary teeth are also at risk of dental caries on occlusal surfaces. I think about 44% of the carious lesions in the primary tooth affect the occlusal surfaces of the molars. Considering these points, please pay attention to this point that although chronic diseases are among the most common and costly of all health problems, they are almost among the most preventable. Therefore, understanding the power of prevention, we can now talk about fissure sealants and preventive resin restorations as one of the most powerful preventive tools. Okay, you know that fluoride and fissure sealants are two critical preventive care in dentistry, especially in pediatric dentistry. Without doubt, the repeated use of fluoride is effective in preventing future lesion development and in arresting or at least slowing the progression of active cavitated lesions and in remineralizing active incipient lesions. But fluoride mostly affects the smooth surfaces of the teeth, and its effects on pits and fissures is less. This has two explained reasons. First of all, accessibility of fluoride to the depth of pits and fissures due to their morphologic characteristic is less. And second, the width of the enamel in the depths of the pits and fissures are less than smooth surfaces. Even you can find some areas without any enamel. And so, to prevent caries in pits and fissures, we should use another tool with better implication in these areas, and that is fissure sealants. Okay, now look at this slide. It shows 5 reasons that shows us the applying fissure sealants may have great benefit on occlusal caries prevention. First of all is the occlusal caries risk. As I have told you, occlusal caries account large percent of dental caries in children and adults. The second one is the pits and fissures morphology, which enhances plaque accumulation, and the less enamel thickness causes these surfaces more susceptible to dental caries. The third one is the eruption time of the teeth. When the teeth erupt, the patient is during his childhood. Because of the age, children are not able to to perform a good oral hygiene, especially for the permanent molars, which are at the distal areas of the mouth. And the next reason is the less fluoride effect. As I have told you, they have less effect on the occlusal surfaces because of the lower enamel thickness and the morphology of the pits and fissures, which makes the accessibility of fluoride to these areas difficult. And the other reason, the immature enamel. When the tooth erupt, their enamel is immature. And so this makes them more susceptible for dental caries. Okay, considering all of these points, it seems necessary to apply fissure sealants to prevent occlusal caries, especially in children. Okay, we have usually 2 types of morphologies in the pits and fissures. You can see here. In the picture A, you can see a shallow, wide, V-shaped fissures, which are self-cleansing and somewhat caries resistant. But in the picture B, you can see a deep, narrow, eye-shaped fissure. These types of fissures are quite constricted. They resemble bottleneck with narrow slit-like opening and have larger base that extends toward dentinal enamel junction. They are, of course, caries susceptible. They have a number of different branches extending toward or extending into the underlying dentin. The fissure sealants indication is better recommended for the type I fissures that are more susceptible for dental caries. Okay, what do you think about the content of the fissures? A typical fissure contains of organic plaque composed of reduced enamel epithelium microorganisms forming dental plaque, and oral debris. The reason of rapidity of dental caries occurrence in these areas is the close proximity to the dentinal enamel junction and also the underlying dentine. And about the morphology of the pits and fissures, in each tooth, the morphology of occlusal surfaces varies from one tooth to another and varies from one individual to another. For example, a typical premolar has prominent primary fissures with 3 or 4 pits, but a typical molar has as many as 10 separate pits, which may be present in primary, secondary, and supplemental fissure. So this emphasizes that the benefit of fissure sealants varies from one tooth to another and one individual to another. And obviously, the fissure sealant indication is better limited to high-risk ones. And now about the histopathology of caries in the pits and fissures. The caries formation on the smooth surfaces is a little different with pits and fissures. On these smooth surfaces, considerable amount of enamel must be involved before dentin involvement. It takes about 3 to 4 years for dentinal involvement, and during this time of during this period of time, remineralization of following exposure to fluoride agents may occur, and this may cause the caries to be arrested, or even the reversal of the lesion may occur. But in the pits and fissures, progression of the lesion to a clinically detectable level is very fast, and this is because of the lessened thickness of the enamel present and also the morphologic form of the pits and fissures that I have talked before. Please pay attention that effectiveness of sealants depends on long-term retention. It means that we should use the best material with best retentive technique to get the best success. And now about the sealant materials. Usually there are 3 types of materials: resins, glass ionomers, traditional and resin modified types. And the last one, polyacid modified resins. The most commonly acceptable material is the resin-based sealants because they have shown superior retention rates, especially compared to glass ionomers. They are retained by a micromechanical retention, and for adhesion of the sealant to the enamel, the tooth must be clean and remain dry because the resin is hydrophobic. The tooth enamel is etched with 35 to 37% phosphoric acid, which creates surface irregularities in which the sealant material flows and forms resin tags. Then the resin is polymerized and forms a thin plastic coating over the pits and fissures of the occlusal surface. And this physical barrier is essential in preventing the caries of occlusal surfaces. And about the glass ionomer cements, they have different bonding mechanisms. They adhere to the enamel to both mechanical retention and chemical bonding. And we can call chemical bonding as chelation. However, the chemical bonding alone is very weak. Glass ionomers are hydrophilic, and so they can withstand some minimal moisture. For application of glass ionomer sealants, the tooth is clean. A tooth conditioner of polyacrylic acid is applied. The tooth is rinsed and dried, and the glass ionomer is placed on the occlusal surfaces. If you use a resin-modified glass ionomer, we should use light cure also. And at last, we can use polyacid-modified resin composites, which are also called compomers. They were introduced as a new materials that aim to combine the aesthetic property of composites with the fluoride releasing property of the glass ionomers. Like composites, they are hydrophobic and they set by a polymerization reaction and require bonding agents to bond to the teeth. Unlike glass ionomers, they release fluoride. But as a sealant material, compomers underperform glass ionomer cements in terms of fluoride releasing and underperform conventional resin composite materials in terms of retention. And also, sealants are often available as clear or opaque types. The opaque sealants are easy to see during application and also easy to monitor during the recall visits. But the clear ones need your tactile exploration, your tactile sense using exploration to monitor the sealant and evaluate it. But there is no clinical differences between these types of sealants. We have also another type of sealant which has the color changing properties. You can see here a clean pro sealant, which is the product of company 3M company. It is pink when you use it and you apply it on the tooth, and after curing, the color changes to the white. You can see here, first of all, before curing, it is pink, so you can see better where you have applied the sealant. And in the lower picture, you can see that this color has been changed to the white. And about the content of the sealants, the filler content of the sealant dictates its physical characteristic. I mean, higher filler content of the sealant causes higher viscosity, lower flowability, and the higher resistance to wear. But the unfilled sealants have some advantages. And these are the lower micro leakage, better penetration into fissures, and the longer resin tags. These advantages means that the unfilled sealants no occlusal adjustment, and I think they have better retention because of the longer resin tags. And what about the indications of the sealants? It is obvious that applying sealant is indicated in deep retentive pit and fissures which are caries susceptible, and then you can feel wedging or catching when you use Explorer. In this stained pit and fissures with minimal appearance of the calcification or opacification, sealant is indicated, and it is very beneficial. When you have restorations or pit and fissure caries in other primary or permanent teeth, it shows that your patient is at high risk, and he can benefit from using sealant. When we have no radiographic or clinical evidence of interproximal caries, which shows the need of restoration in the tooth that should be sealed. When the patient uses other preventive treatments, such as a systemic or topical fluoride therapy, which inhibits interproximal caries formation in the patient. And where the very important one is the possibility of adequate isolation from salivary contamination. Of course, if you cannot isolate the tooth, you should not use this type of treatment. And the development of pit and fissure caries in permanent molars may occur up to 16 years after the eruption. So the age is not the determining factor in applying fissure sealants, and you can use when a teeth or when a patient is at high risk of dental caries. And also the patient should be cooperative, because if he or she is not cooperative, you cannot get a good isolation for your process. And of course, when you know the indications, you can imagine the contraindications easily. When we have a cold seal self-cleansing pit and fissure, we don't need to seal that pits and fissures. When we see radiographic or clinical evidence of interproximal caries which need restoration of the teeth, when the interproximal lesions are present in the teeth and the patient uses no other preventive treatments to inhibit interproximal caries formation. And also when the tooth is partially erupted and no possibility of adequate isolation is there, then you can delay the treatment. Okay, look at these pictures. When the tooth is semi-erupted and the operculum is over the teeth, over the distal marginal ridge of the teeth, loss of sealant material and need of the reapplication of the sealant increases to about 54%. And this shows that in these cases, you can choose the other options. Okay, if you can delay the treatment, please do it. But if the tooth is at risk and you cannot delay the treatment and the tissue retraction is not possible, you can choose, you can have some options. First of all, you can have surgical removal of the operculum, and after healing of the soft tissue, you can do the sealant application. You can use hydrophilic bonding agent layer prior to placement of the sealant material to increase the bonding strength. You can use glass ionomers as sealants because, as I have told you, they can withstand to a little moisture in your process. You can see where you can see and then follow the other places. But of course, the close follow-up is needed to evaluate any loss of sealant material in these clinical cases. And what about the sealing initial caries? Today, it has been told that sealing over non-cavitated reduced the probability of lesion progression by more than 70%. And how does it work? The sealant reduces the bacterial levels in lesion because acid etching eliminates about 75% of the viable microorganisms, and also they retain slight deprive bacteria of access to the nutrients, and so they will die. And now let's go to the work. And about the process, in the first step, you should clean the tooth. You can do this step by using an explorer and forcefully rinsing with an air water spray. You can use a dry bristle toothbrush. You can use a pumice slurry and a rubber cup. And the last one is air polishing system such as Preventive. But if you have it and you have access to this system, you can use it. After cleaning the tooth, you should isolate tooth from salivary contamination. Ideally, you can use rubber dam for your isolation, but cotton roll isolation with adequate suctioning to remove saliva from the operating field is also acceptable. And this is the preferred technique for isolation for many practitioners. In the step 3, you use acid etch and you apply the acid etch using a fine brush or a cotton pledget or a mini sponge. You will apply the acid etch from 15 seconds for permanent teeth to 15 to 30 seconds for primary teeth. Additional etching time is needed for fluorose teeth, and gently rub the etchant material on the tooth. We should include 2 to 3 millimeters of the cuspal inclines and reach into the buccal and lingual pits and grooves that are present and are caries susceptible. Please avoid splage of the etchant onto the interproximal surfaces because it causes gingival irritation, or sealing of the adjacent interproximal surfaces may occur. We have 2 types of sealant etchant, acid etch. They are in the form of gel or liquid agent. Using gel is easier because it has increased control, and the likelihood of the splage onto the interproximal surfaces is decreased. And the next step is rinsing and drying the tooth. You should rinse the tooth at least for 30 seconds. If you use cotton roll isolation, please replace the wet ones with dry ones and make the isolation again. Then using the an air spray, you should dry the tooth for at least 15 seconds. The dried etch enamel has a frosted white appearance. If you don't see this appearance, please repeat the etching process again. And if the salivary contamination occurs at this stage, please re-isolate the tooth, rinse the entire tooth surface, dry thoroughly, and repeat the etching process at least for 10 seconds. If it is impossible to avoid salivary or water contamination, application of a hydrophilic bonding agent prior to sealant application is recommended. And the next step is applying bond and sealant to the etched tooth surface. Using bonding agents when you use sealant materials is optional, but if you use the composite resins as a sealant, the bonding agent must be used. Applying the bond to the edge surface in this step is the first thing that you should do. Then light cure the bond. After that, you can use the sealant material in the mandibular teeth. You apply the material at the distal aspect and allow it to flow mesially, And then on the maxillary teeth, you apply it at the mesial aspect and allow it to flow distally. And this is because of the curve of the spit and the position of the head and neck during the application. Prevent incorporation of the air, you can do it by using a micro brush or using a burnisher. Carry a thin layer of the cuspal inclines, again using a micro brush or a burnisher. Then flow the sealant into the buccal and lingual pits and grooves, which are caries susceptible. Additional time of 5 to 10 seconds makes you get a maximal penetration of the sealants and bonding agents to the etching tags. And if the curing is delayed for 10 seconds, you have 300% penetration based on the resin tag length. And the next step is exploring the teeth and finding any void if there is in your sealing surfaces. If deficiencies you can see, please apply additional sealant material before your isolation is abrupted. Usually a sticky layer of apparently unreacted sealant will be present on the tooth surface. This is an air-inhibited layer of sealant that has not undergone polymerization, and it makes a bad taste in the patients. And then if everything is okay, you can now remove the rubber dam or cotton rolls. And after that, you have to do the occlusal adjustment, especially when you use the composite resins as the sealant materials. Okay, you can use the clinical process here. This is the first step when you clean the tooth with a brush. The next step is when the tooth has been etched, you can see the chalky white appearance of the enamel. And then the bonding agent and the sealant material has been applied to the tooth, especially to the buccal grooves of the teeth, and then cured. And this is another final picture of the fissure sealant application on upper molar. And this is the another one. Pay attention to the burnisher you can see here, which is used to extend the sealant to the cuspal inclines. And about the troubleshooting, if the sealant material depends upon immediate evaluation, debris may be remained in the fissures, so the bonding and the etching may be disrupted because of this. And salivary contamination may be occurred during your etching or bonding, and the tooth may be was not completely dry after the rinsing step. And then if you have this happening in your procedure, you should do the process from the etching step again. Don't forget to follow up your patient, because this is the very important step in your clinical procedure. If we usually have the most failure of the fissure sealants in the first year after the application, so please do have the close follow-up of your patients. Okay, now we can go to talk about preventive resin restorations, which are called also as conservative adhesive restorations. They were first described by Simpson and Stallard, and they were first called conservative adhesive restorations. And their concept was sealing susceptible pit and fissures and conservative cavity preparation of caries occurring on the same occlusal surface. It has a limited cavity preparation just to the discrete areas of decay, and it can be filled with adhesive materials, composite or conformers, and they're sealing the entire occlusal surfaces with the sealant or with the same composite. It is also therapeutic and preventive, and you can use other adhesive materials besides resins. There are originally 3 types of preventive resin restorations, A, B, C, or 1, 2, 3. They represent a continuum of tooth preparation and caries activity, with type 1 being the most conservative and type 3 the least. The teeth that are suitable for caries preventive resin restorations demonstrate small, discrete regions of decay, often limited to a single pit. And the single most important indication is the ability to isolate the tooth and keep it dry through the procedure. During this type of treatment, you may not have any requiring any anesthesia because we need a minimal tooth preparation, but it is not for all of the cases. But usually we don't need, and soft tissue anesthesia may be necessary if you use rubber dam for isolation. Okay, here you can see the an abstract of the process. The decay of the tooth in the discrete areas have been removed, and it is filled with composite, and overall all surfaces of the tooth has been sealed with sealant. We have, as I said, we have two types of preventive resin restorations. The type 1 is the minimally preparation. It is just sometimes widening of the pits and fissures with a very small round burr or a fissurotomy burr. It is confined to enamel. The process is etching, applying sealant, and the last one, polymerization. But in the type 2 preventive resin restorations, you use a small round burr to remove the decay, and when the preparation extends to the dentin, the process is etching, rinsing, drying, applying bonding agent, using a wear resistance based composite or compomers with a brush or plastic instrument, and then excess resin into the adjacent pits and fissures. And the last one is polymerization of the entire surface. In the type 3 preventive resin restorations, they are very similar to type 2, except that the sealant layer forms an integral part of the restoration. It's also the cavity extends to the dentin, and we use a very resistant resin only for restoring the cavity preparation and seal the other surfaces of the teeth and also on the cavity that you have prepared with sealants. Okay, you can see here when the cavity preparation is very deep, you use glass ionomer cement as a base at the depths of your cavity. Then using composite resins to replace the dentin and enamel, and overall of the teeth should be sealed with fissure sealants. Okay, can you see the differences between the upper pictures and the lower ones? In the upper picture, you can see the caries limited to the enamel. So after removing the caries with the high-speed instrument, you can seal the cavity and also other pit and fissures with sealant. But when the cavity extends to the dentin, you should use a composite resin to replace the dentin. In the deep ones, you can use also the base under your composite, and overall of the teeth is sealed with the sealant. Again, here you can see there are just two areas that are deeply instrumented, and the cavity is deep, but the other areas without any preparation is sealed after filling the cavity preparation. Here, the practitioner applies the bond in picture D, and then applying and placing the composite resins in the cavity preparation. After all, using a burnisher, he or she extends the material to other pits and fissures, and this is type 2, PR type 2. After all, you in the type 3, you seal the other surfaces with sealant material. It's fissure sealant. And if you use resin composite, you should have also occlusal adjustments. Thank you very much for your attention. I have also a short video of applying fissure sealant on a teeth. Okay, you can see here, this is the isolation with cotton rolls, drying with air spray, applying the etchant material on the tooth, and of course on the buccal grooves of the tooth. Etching process may be for 15 to 30 seconds for primary and permanent dentitions. After spending the time, the tooth is rinsed with water. Again, having the isolation with cotton rolls with dry ones, drying the tooth. Here, you must see the white and chalky appearance of the enamel. Using bonding agents on the tooth. Using an air spray and then curing. And after that, using a sealant material to seal the susceptible pits and fissures. This is the color changing type. It's pink during the application. It is extended to the cuspal inclines and also to the buccal grooves of the teeth. The extending and removing the voids is done with the microbrush. And then curing. Before your isolation has interrupted, you can evaluate the tooth. And if it is okay, you can remove the rubber dam and cotton rolls. And this is the last picture. If you use resin, composite resins for sealing, you should have the occlusal adjustment too. Thank you, Dr. Milani.
Thank you, Dr. Mukhtari, for your very informative speech. I think, dear students, if there are any questions, we are ready to answer. If you have any questions, you can write in the chat box. I can see that Dr. Saeb Alizadeh has written a question. Is written, Doctor, I just want to know, for deep caries after applying composite resin, do you use acid etch again in fissures for sealant?
In the first step, we use acid etch for the entire surface, and when we apply the composite resins, we don't need to re-etch the tooth surface if the isolation is okay and the salivary contamination has not been occurred. It does not need any reusing of the etch.
Thank you. Any other questions? During this time, the students are thinking, I want to address again, full emphasis on the importance of isolation when you are doing fissure sealant and preventive resin restorations. As I told at the beginning of our session, I told you these treatments might seem very easy because they are not properly involved, but even if they are not done precisely, after some time you will have very bad consequences because of the micro leakage. And for example, a patient comes to you with a chief complaint of, for example, having fissure sealant as a preventive treatment, but you may have the child again in some months as with recurrent caries and with endodontic need. You know, it's very important to completely isolate and follow the steps as it has been written in your textbooks or references. Thank you again, Dr. Mukhtari. I think
Thank you too.
there are no more questions. Thanks again. Thanks a lot. And I think
thank you very much for you. And if you don't have any question,
we have another question. After entire etching, all surfaces will be demineralized. So what